Hi, my name is Carla Diaz, and the topic of the exposition is oral semaglutide and cardiovascular outcomes in patients with type 2 diabetes. First, I'm going to explain the definition. Okay, cardiovascular disease is the primary cause of death in patients with type 2 diabetes, and the rolling out of an excess cardiovascular risk is a regulatory requirement for new glucose lowering therapies. What is diabetes, specific the type 2? Is a common condition that causes the level of sugar, glucose in the blood to become too high. It can cause symptoms like excessive thirst, needing to pee a lot, and tiredness. It can also increase your risk of getting serious problems with your eyes, heart, and nerves.
Okay, continue with the application in medicine. Application in medicine. Glucagon-like peptide 1 receptor agonists are well-established glucose-lowering medication for the treatment of type 2 diabetes and are associated with reduction in body weight and a low risk of hypoglycemia. Next, I will present a video of GLP-1.
GLP-1 is an incretin hormone released by endocrine cells in the intestine in a response to oral food intake. What are incretin hormones? Watch our previous video. The link is in the description, or click the I button above. GLP-1 is a natural blood sugar regulating system in your body. When you eat a meal and it reaches your intestines, GLP-1 hormones are released. GLP-1 hormones are released in two phases, with the first phase lasting 10 to 15 minutes, followed by a second phase 30 to 60 minutes after food intake. GLP-1 is rapidly metabolized and inactivated by the enzyme DPP-4, even before the hormone has left the intestine. In our next videos, we will discuss this enzyme and its role in blood glucose regulation. The main action of GLP-1 is to stimulate insulin secretion and inhibit glucagon secretion. GLP-1 stimulates beta cells to produce insulin. It blocks glucagon secretion from pancreatic alpha cells. GLP-1 also slows gastric emptying and suppresses appetite in the hypothalamus. In this way, it limits postprandial glucose excursions. GLP-1 acts as a physiological regulator of appetite and food intake, leading to normalization of blood glucose levels and a positive effect on weight loss. Decreased secretion of GLP-1 hormones may contribute to high blood sugar levels and obesity. Excessive secretion of GLP may be responsible for postprandial hypoglycemia. Because of these effects, GLP-1 or GLP-1 receptor agonists are currently being modified to prevent type 2 diabetes. In our next video, we will explain the GLP-1 receptor agonist, which enhances the effect of GLP-1 hormones and improves blood glucose levels in diabetics, and is also used for weight loss in overweight people. Share this video.
Pros and cons. Pros. Glycate hemoglobin levels decrease more in the oral semaglutide group than in the placebo group. Systolic blood pressure decreased more in the oral semaglutide group than in the placebo group. Cons. Serious adverse events occur in 301 of 1591 patients. The gastrointestinal adverse events in the oral semaglutide group are primarily nausea, vomiting, and diarrhea, mostly no serious. Next, the video.
Globally, over 450 million people have diabetes, and this number is projected to rise over the coming decade. Type 2 diabetes accounts for over 90% of diagnoses worldwide, and current management guidelines for type 2 diabetes prioritize the use of glucagon-like peptide-1 receptor agonists, or GLP-1RAs, in specific populations and before insulin therapy. Semaglutide is a medication that binds to and activates the GLP-1 receptor. It was shown to be both effective and safe in treating type 2 diabetes in 10 clinical trials known as the SUSTAIN trials. These trials included a heterogeneous population of patients with type 2 diabetes. Therefore, it would be helpful to know whether semaglutide is equally effective and safe across all subgroups of patients. A new post-hoc analysis re-examined the Phase 3A data from the SUSTAIN 1-5 trials to assess any differences in response to semaglutide among patients with different clinical baseline characteristics, such as HbA1c levels, background medications, diabetes duration, or pancreatic beta cell function. The researchers found that those with the poorest pretreatment glycemic control, reflected in the highest initial levels of HbA1c, saw the greatest improvement over the 30 weeks of semaglutide treatment. This resulted in similar post-treatment levels of HbA1c among all groups. In contrast, reductions in body weight were greater for those with lower initial levels of HbA1c. Compared with treatment with semaglutide 0.5 mg, treatment with semaglutide 1.0 mg resulted in greater improvement in both HbA1c levels and body weight, independent of any patient differences such as background medication, diabetes duration, or pancreatic beta cell function. Semaglutide was found to be safe across all patient subgroups, with similar, mostly mild adverse events occurring in all subpopulations of patients. These results show that semaglutide is both effective and safe for treatment of type 2 diabetes in a broad spectrum of patients with a range of clinical baseline characteristics.
Issue applied in Ecuador. Statistics in Ecuador. In Ecuador, diabetes is affecting the population with increasing rates. According to the ANSANUT survey, the prevalence of diabetes in the population aged 10 to 59 is 1.7%. That proportion goes up from the age of 30, and at 50, 1 in 10 Ecuadorians already has diabetes. And the last one is the conclusion with a video. Conclusion: this cardiovascular outcome trial met its primary objective of ruling out an 80% excess cardiovascular risk with oral semaglutide. This finding is consistent with those of other published cardiovascular outcome trials of GLP-1 receptor agonists, all of which confirm the absence of excess cardiovascular risk. And the video.
Over the past 2 decades, several studies have highlighted the importance of intensive glucose-lowering therapy, blood pressure control, and statin use to reduce the risk of cardiovascular complications and mortality in patients with diabetes. But the long-term trends of mortality and cardiovascular outcomes of patients with type 1 or type 2 diabetes as compared with the general population are unknown. In a study of patients enrolled between 1998 and 2012 in the Swedish National Diabetes Register, a total of 36,869 patients with type 1 and 457,473 patients with type 2 diabetes were included, along with matched controls from the general population. The outcomes that were assessed were all-cause mortality, fatal coronary heart disease, fatal cardiovascular disease, and hospitalization for cardiovascular disease. The rate of all-cause mortality declined among those with type 1 diabetes by 29%, and in matched controls by 23%, a difference that was not statistically significant. The rate of hospitalization for cardiovascular disease decreased by 36% among those with type 1 diabetes and by 9% among matched controls, a decrease that was significantly greater for the diabetic group. The rate of all-cause mortality decreased by 21% among those with type 2 diabetes and by 31% among matched controls, a statistically significant difference that favored the control group. The rate of hospitalization for cardiovascular disease decreased by 44% among those with type 2 diabetes and by 29% among matched controls, a statistically significant difference that favored those with type 2 diabetes. The authors conclude that mortality and cardiovascular disease have declined for patients with diabetes. For most cardiovascular outcomes studied, event rates have decreased at least as quickly for patients with diabetes as for matched controls. However, as compared with matched controls, patients with type 2 diabetes had a smaller reduction in fatal cardiovascular outcomes. Full study results are available